Okay, so let's go ahead and get started. Today we're going to talk about pharmacology and really just knowing your endings. This webinar is going to be in three parts: part one, part two, part three. That means three parts. And we're going to kind of talk about different sections in each part. The first part's really kind of how to get started and go over the high yield, like hypertensive drugs. The next part, second part, is antibiotics. And the third part really is just kind of a hodgepodge of other drugs kind of mixed in there. So let's go ahead and get started. Excuse me. First off, my name's Kendall Wyatt. I am the Picmonic's content director, so I manage all the content for everything. I started out as a paramedic, went to nursing school, then went to med school, just finished up. But that's enough about me. You don't need to know about my stuff. Picmonic takes everything you need to know in nursing school and turns it into fun images. So nursing school, med school, PA school, basically anything medicine. So if you had a bipolar disorder, you could remember it with something like this bipolar bear, which is really handy. We cover lots of different topics for all the things you need to know. So first off, when we talk about this topic today, it's kind of what are we going to do? We're going to talk about medication endings and some antihypertensives in part one. And like I said, part two is antibiotics. Part three is just going to be some, other medications kind of in hodgepodge. And of course, as always, I always have my little magic cup here. One, because my mouth gets dry. Two, because I make 3 cents every time I shove that off. So whenever you do pharmacology, it's really important not to really drive the home, but it's a lot of memorization. There's tons of medications, so many things to remember, and I can tell you, you can maximize what you're learning just by learning the drug endings, and that's really what we're going to talk about today. All of the images and everything you see in our presentation today are all included on Picmonic's website. You can sign up for a free account at picmonic.com, and there's some links down below. So we're going to talk about, there's so many different medications. We're going to talk about how to identify drug endings and memorize those. And then what you really want to know are just memorizing really key points. You don't need to, at least at the nursing level, to master every single tiny little detail. And you don't need to focus on like the big things, like does this medication cause nausea or vomiting? Well, almost every medication can cause nausea, or upset stomach, or GI distress, or diarrhea, constipation. But you want to remember the obscure things. Does this medication cause a bowel ileus? Does this medication cause projectile vomiting? Or does it cause a cough? Does it cause, what are the key ones or the signs and symptoms, or the side effects, rather, of that particular medication? That's what's really important. When you look at pharmacology and drugs, you need to remember, again, key points. We're going to talk about drug endings today. You need to know the mechanism of action. So depending on what level you're at, if you're, still starting out, you don't need to know great detail in physiology and tiny mechanisms of action. But if you're at a higher provider level or med school or MP, PA, you really need to know those mechanisms of action and all the physiology behind it. You got to know why you're given the drug, indication, and those side effects, of course. Remembering high yield, key fact side effects, that's what's important. Considerations are just extra things, some things we're going to talk about today, and so that you can remember, because they're important things you need to tell your patients. So let's get started with part one. Part one, we're really going to talk about mostly antihypertensives. We're not going to talk about every single one, but really the highest yield. If there's one thing you must know, no matter what level you're at, you've got to know every detail about these medications. There's no skipping here. So antihypertensives, we've got our ant wearing a tie with our hiker BP character for antihypertensives. And everything you're going to see here is consistent. Now the first one I like to always start off with is one of my favorites. It's beta blockers. Beta blockers, as soon as I say beta blockers, you should say beta blockers. You should say beta fish, right? And we've got here our character, which is a blue beta fish. Now, the way we're going to talk about, staying in line are beta blockers, knowing the drug ending. Well, beta blockers always, a few rare exceptions, and for good reason, end in OLOL. So OLOL, you need to remember that. Well, I like to remember here at Picmonic, we have our blue beta fish sitting on these blocks for beta blocker, and then we've got, of course, licking a lollipop, a fish with lips licking a lollipop. Oh my goodness, I know, it's just great. I love our little beta fish here, it's so cute. But just by learning that right there, you can learn tons of different beta blockers. There's so many different ones. Look at this list of beta blockers here. There's so many different ones. And there are a couple of key ones that end in ALOL, which means they have alpha blocking capability as well. But that's not what we're going to stick with today. Learning this, you can immediately learn a beta blocker. Now, there's one thing you should be thinking about. When I say beta blockers, what do you need to be thinking about when I say beta blockers? What is the one thing you need to monitor or worry or watch for when I say beta blockers? I say beta blockers, you say heart rate. That's right. You really got to worry about monitoring the heart rate because beta blockers cause a beta block, and one of the things where we have a beta receptor block is for heart rate. Now, here's our beta blockers Picmonic. You can learn this inside of our learning system. Lots of different things here, but beta blockers, again, a beta fish on blocks with a lollipop, to remember that ending. We use beta blockers for hypertension or hyper BP, heart failure, and angina, our little angel guy here. So you can remember that, and what you need to do is always check the heart rate. Now, I always get a nurse that would come to me and say, well, what if I get a low heart rate? I can't tell that patient not to take their medication. And you're right. At the nursing level, you can't say, stop taking your medication. But you can tell them to hold a dose, and you can notify the provider. Anybody who's a practitioner would just say, stop the medication, or maybe we need to lower the dose or switch you to a different type of medication. All of these medications, beta blockers, there's a big one. What do we need to monitor for or what do we need to be worried about with a patient who's on beta blockers? Well, we need to be worried about the fact that heart rate, number one, but also be worried about the fact that beta blockers can mask the signs of hypoglycemia. So we've got our little masked hippo glue bottle right here inside of Picmonic, just a little cute little nugget right there. And what are those signs and symptoms? Well, beta blockers block beta receptors, and when they block beta receptors, they prevent the release of epinephrine. And that prevention of epinephrine, when you get a low blood sugar, your body throws out a bunch of epinephrine, and when it throws out that epinephrine, it causes those systemic symptoms. What are they? Well, that's going to have a little bit of tachycardia, which is beta blocker blocks. You're going to have a little bit of sweating, a little bit of diaphoresis, and you're not going to get those symptoms without that epinephrine because of the beta blocker. So it masks those signs of hypoglycemia. You need to remember. Also important not to give a beta blocker in a patient with a heart block. We've got our heart whip blocks here wrapped in caution tape, or for asthma because it can cause bronchoconstriction. Just important points. All of the drugs, almost every drug really, you never really want to stop them cold turkey, and all these ones we're going to talk about, you'd want to taper them down or switch them to another medication. But in general, it's a bad idea to stop any medication right away. But there's a couple that you need to remember to taper as well, like steroids. So let's get started with the next one that I like, and that's ACE inhibitors. ACE inhibitors, angiotensin-converting enzyme inhibitors. Now, if you don't understand the renin-angiotensin system, well, I'm sorry. No, I'm just kidding. You can go check out our other webinar. We got one on renal, or lots of Picmonics on renal, tons of different things to help you learn all those and all the drugs. But we're just going to talk about ACE inhibitors first. ACE inhibitors. Now, ACE, angiotensin-converting enzyme, is in the lung, right? That's right. Angiotensin-converting enzyme inhibitors prevent the conversion of angiotensin 1 to angiotensin 2. So when I say ACE inhibitors, here we've got our wonderful little character, our ACE card with inhibiting chains, and we've got what? Well, we've got our little pearls, because ACE inhibitors end in pril. That's right. So ACE inhibitors end in pril. So we've got the fun little pearls here with our ACE card with inhibiting chains. Little ACE card, just got the little chain there. Poor little thing. Anyway, so ACE inhibitors, you need to remember pril, P-R-I-L. So you're going to learn lots of different ACE inhibitors just by memorizing the drug ending. But if I say ACE inhibitors, the first thing that should roll out of your mouth is, what side effect do we have to watch for right away? It should be at the tip of your tongue. You should be spitting it out. Cough, that's right. Cough, a dry cough. ACE inhibitors, because of the inhibiting ACE, it also inhibits bradykinin. And bradykinin basically causes a decrease of secretions, or a decrease. It allows for irritation basically in the throat and can cause this dry cough. That's a number one reason we'd need to look for. It's a very high yield question, and we'd want to switch them to another type of medication. So, a really common thing is that a patient who has on an ACE inhibitor, if they get that dry cough, we're going to switch them to another medication. But before we do that, let's take a look at our ACE inhibitor Picmonic. So you can take a look here. Here's our ACE card. Again, our little renin wrench character and our raspberries for renin-angiotensin system. But what are the other side effects of ACE inhibitors? Well, anytime you give an ACE inhibitor, an antihypertensive, you worry about the opposite effect of what you're giving it for. So you may have hypotension or hypo-BP. There's that coughing coffee pot right there with his dry mouth to help you remember cough for ACE inhibitors with pearls on the table for pril. Other things we see are hyperkalemia, our hyper-banana character, and sometimes we'll see angioedema, but not so common with ACE inhibitors. Other thing we're going to see with ACE inhibitors is a first dose effect. So very first dose. So here we've got our slow turtle standing, sort of slow position changes, because you get that first dose effect where, you may have a little bit of syncope on rising. So you want to tell them to raise up real slow. The next medication type after ACE inhibitors, if you had an ACE inhibitor and you needed to switch, you're going to get switched to an ARB, or an angiotensin receptor blocker, or angiotensin II receptor blocker. That's why we call them ARBs. It's such a mouthful, so many words. So ARBs are another type of medication, and you need to remember those by what drug ending? Well, sartan. Losartan, candesartan, valsartan, omelsartan, or whatever other sartans they make. There's so many. They're going to make some new sartans tomorrow, and you're just going to have to remember that one too, right? No, you're going to be able to just remember the drug ending. I don't know of any other sartans that aren't angiotensin receptor blockers. So easy to remember. And you can remember this with this crazy image here of our angiotensin receptor blocker here, angel 22 wearing receptor. I got my mouth is so tongue-tied today. But this angel playing tennis with her little receptor blocks, and she's wearing a tutu. So for angiotensin 2 receptor blocker. But most importantly, you can remember this little Spartan character that he's playing with to help you remember sartans, and that's what's really going to help you. So you can remember those endings. Now, when I say angiotensin receptor blockers or ARBs, what's the thing you need to worry about? That side effect on the tip of your tongue. Well, the first one, the big one we see a lot, is really just remembering angioedema. So angioedema, possible with ACE inhibitors, yes, but very possible with angiotensin receptor blockers. And here we've got our little angel edamame with lips. See that edamame little thing right there? Just so cute and big old. Why are we doing that? Well, because that's usually where you see angioedema. You usually see it in the lips. It's usually swelling in the lips, and you end up with the. That's right. You're not going to forget that, right? I know. Oh, yeah, I know. Just play it back and watch it again and again. I don't mind. Anyway, that's what you worry about, angioedema, that swelling and, dilation of the face, a medical emergency for sure. Of course, other things, we worry about a lot of these types of medications because we don't want to use them in pregnancy, or they're cautioned in pregnancy for sure. Definitely a second-line medication. Or renal artery stenosis. Here we've got our little stone kidney vessel character for renal artery stenosis. Now, the next medication type I want to talk about, another type or class of medications are calcium channel blockers. I love calcium channel blockers because I just love this cute little cow. But anyway, calcium channel blockers, there's several different types. I'm going to talk about those in a sec. But calcium channel blockers, as far as an antihypertensive, you need to remember are the dipines. Nifedipine, amlodipine, nifedipine. That's right. You need to remember those right there. Now, with those, you can remember the dipines, calcium channel blockers, and you can remember that this little cow character, right? Our calcium calcified cow with these little blocks, and of course they're dipping their little chips. So dipines, you can help remember. So the big thing to know with these is that when we talk about calcium channel blockers, especially if you're super smart, you would say, oh, well, that's not the only type of calcium channel blocker. And I'd say, oh, well, that means you're right. You're so smart. Ooh. So there are three different classes of calcium channel blockers. There's the ones for hypertension, which are the dipines, the dihydropyridines. You don't need to know that dihydropyridines so much, but they're just the dipines. The other ones are the phenylalkylamines. The phenylalkylamines are verapamil. That's another one you've probably heard of. And the benzothiazepines, which is diltiazem. Now, why is there three different classes? Well, the easiest way to remember is that the dipines are for hypertension, and those are definitely vasoselective. Whereas verapamil and diltiazem are cardioselective and vaso. They work on cardiac and the vessels, but mostly cardioselective. So they're going to work on the heart. So why do we use diltiazem? Oh, I just don't know. I just can't remember. I've got this diltazer and this V-wrapper in this image. I just don't know why we use it. Well, that's why we have Picmonics, because they help you remember everything. Diltiazem is a cardioselective calcium channel blocker. We block calcium channels. We stop excitability. We slow it down. We calm it down. Calm down, calcium. You don't need to get so excited. Getting all those channels excited. So we usually see diltiazem used in atrial fibrillation for rate control. Verapamil we see often sometimes used in the same type of way. And of course, the dihydropyridines, the dipines we use for blood pressure. I'm just so tongue-tied today. Probably because I'm talking so fast, but luckily you can just play it over again. Anyway, here's our calcium channel blockers, Picmonic. So we've got our diltazer and our V-wrapper up here at the top with this calcified cals blocked. Now, when I say amlodipine, nifedipine, and I talk about one of those calcium channel blockers, what's the number one side effect you should be looking for, especially no matter what level you're at? You should be looking for this common side effect. And what is it? Oh my goodness, I don't know. Hypotension? No, that's not the one I'm going to be trying to give you. That's the easy answer. If I'm giving you a medication for blood pressure, obviously a side effect is low blood pressure. Duh, right? That's not the one you're going to get. You're usually going to get peripheral edema. We see it all the time, peripheral edema. If you're on a calcium channel blocker for hypertension and you end up with this constant peripheral edema or edema in the legs, it's probably because of the calcium channel blocker. Super common. See it all the time. Now, the other one that we see, when we use diltiazem or especially verapamil by itself usually causes what? Verapamil we see causes constipation. That's another side effect. So we got the little quart con toilet here inside of our image. And gingival hyperplasia. The only other time you see gingival hyperplasia, you should be thinking about seizure-type medications. That's right. But of course, any type of calcium channel blocker can slow the heart rate down. But, you want to worry about, with those dihydropyridines, you want to worry about that peripheral edema because that's really common. Now, the next thing I want to talk about are loop diuretics. Now, I'm not going to talk about all the types of diuretics because we've got that literally in our renal webinar. We go through every single one of them. But we're just going to talk about loop diuretics first. Now, loop diuretics are fun because we've got our dye rocket spewing out urine or yellow fluid if you don't want to say the word urine out loud if it makes you nervous, or you just say poop or something and then you freak out. Maybe you go to a naughty place or a bad place in your mind. You're just in the fetal position crying. But anyway, loop diuretics. Here we've got our loop hin. Now, what's important? Now, really, this is kind of a stretch for us on the ending because it's not really a drug ending for all loop diuretics. But I just want to talk the few ones you're going to get. So you're going to see Semide, S-E-M-I-D-E. And that's where you've got furosemide and torsemide. And I've got these other two here in red because they're different. But furosemide or Lasix, don't use that trade name. Always remember the generic name. Always remember that, really important. So we got our loop dye rocket hen on this, this semi-truck spewing out urine. And why is it spewing out so much urine? Because loops are very powerful diuretics. Now, just really quick, ethicrinic acid. I mean, that's such a weird one. Well, let's just talk about why you need to remember the different one. Like, why is ethicrinic acid? Why is it different? Because it's spelled differently? Because it's two words? I mean, I don't know. Well, the reason is because ethicrinic acid is literally a loop diuretic, but it's the weird one. Remember, it's a weird name, and it has a weird name for the reason, in my opinion, and I remember that it has a weird name because it doesn't have salt. It's not, you can give it to a person with sulfa allergy. There's no sulfa allergy interaction. Whereas loop diuretics, you can't give to a patient who has a sulfa allergy. Really common question we see. So here's our loop diuretic Picmonics. Now, I'm not going to go through each of the details, but there's a couple really important points when we talk about giving loop diuretics. The first off are that when we give any diuretic, it basically makes you pee a lot, right? I mean, you're urinating more. Now, when you're urinating more, you're losing more things. Now, I always love loops lose everything. And when I say loops lose everything, I mean you're peeing out all those electrolytes. You're peeing out everything. And what's that little old volatile, scaredy electrolyte that just gets so scared and gets all out of whack every single time? Which one is it? Oh, a scaredy electrolyte. I don't know. Potassium. And I always just like to remember potassium. Potassium's in bananas. Bananas go so bad so quick. You know a weirdo that doesn't like to eat a brown banana. Actually, I do. It's Marley. She works here at Picmonic with me, and she loves brown bananas. What a freak. Who wants to eat brown bananas? Oh, you can send them here to the Picmonic office, and Marley will eat them if you get some brown bananas. Fine. Anyway, with that, little volatile electrolyte. And with that, you pee out extra potassium. We see it with loops. But loops lose everything. Remember that. Loops lose everything. So you're going to pee out potassium first. It's going to be the first one you're going to pee out because it's just scaredy electrolyte. Then you're going to see loops losing calcium. That's really, really important. Loops lose calcium. So loops lose calcium. Well, why do I tell you that? Well, pees out everything, because I'm going to talk about the difference in a second. Now, with loop diuretics, if you're giving them for a long period of time or a high dose IV, what do we worry about? What's the thing we're going to be watching for? We're going to be watching for, looking for out there, like what's going on? I don't know. Well, we're going to be watching for ototoxicity. I'm going to pull my shirt down, sorry. Ototoxicity. Ototoxicity. What does ototoxicity mean? Toxic ears? Yes, we've got our toxic green glow here inside of our Picmonic. But you're going to be worried about tinnitus or ringing of the ears. That's going to be that sign for a patient who's on a loop diuretic drip or getting a high dose IV. So with all this, lots of things to go with loop diuretics. What's the big thing we're going to worry about next? What's the next type of diuretic we want to talk about? Well, that's going to be thiazide diuretics. Now, we're going to talk about thiazide diuretics at the second, but remember that thiazide diuretics are different because they don't lose calcium. That's why we remember, if you remember that, loops lose everything, loops lose calcium. So you have hypocalcemia, whereas a thiazide diuretic, no change. So that's it for part 1. We're really just moving straight on to part 2. It's no different for me, but if you're switching videos, you need to switch over to part 2. Make sure you subscribe to the channel. Make sure you click over to get to the next video. Just make sure you just show us some love. We accept free candy. Marley likes brown bananas. And just about, I don't know, just love. Just send us comments. But if you're angry and you just want to say mean things, just go home. Just close your laptop or something. Just don't watch. I'm not making you watch. It's fun, right? So we'll see you in part 2. We're going to talk about antibiotics. And to continue on, pharmacology, knowing your endings. We'll see you over there.